There it goes. All
I
right.
see everyone.
Yes. Now everybody's in. Welcome everybody. We are so excited you're here to join us tonight. And tonight's topic, we're going to talk about menopausal hormone therapy, long-term use of menopausal hormone therapy. What are some of the risks and benefits? How do we counsel patients on this? It's somewhat similar to a topic we've done before, but I think it's something that comes up over and over again. So it's really worth walking through some of the detail on again. And, I think so many of our patients come to us and say, oh, this person told me I have to stop. I'm too old. I've been on it too long. So let's really explore what do we have data-wise to talk about that. And to do that with me tonight, I have Dr. Hannah McDashie. She is one of our medical directors here at Genève, and is an OBGYN and a minimally invasive gynecologic surgeon with an expertise in menopause. So Hannah, why don't you tell us a bit about yourself?
Yes, hi everyone. So I'm Hannah McDashie. I'm an OB-GYN by training. I did my residency in Virginia and then proceeded with a fellowship in minimally invasive GYN surgery in Seattle. And it was actually after my fellowship training that I really got into the into menopausal medicine and the menopause space. And that's when, when it really dawned on me that a lot of the time and effort and energy in OB-GYN is usually on pregnancy related issues, taking care of women during pregnancy and after pregnancy. But then we had this huge cohort of patients who are in perimenopause and postmenopause, and there was not a lot going on in that space at that time. So super excited to see that there's a lot more interest in women's health beyond pregnancy. And that's how I became a certified menopause provider. And also, one of the things that popped up with the peri and postmenopausal patient populations was issues in weight gain and difficulties controlling weight with menopause. And so that's how I got into the obesity medicine space, and I got board certified in that. And so super love working with perimenopausal and postmenopausal women. So thanks for having me on, Becca.
Of course. So I'm going to start by asking you a question, which
Yes.
is there an age or number of years where menopausal hormone therapy has to stop?
No. So
Yay.
that's the short. That's yeah. I was gonna say. So no is the short answer to both of those questions, which
Mhm.
is there a definitive age where all women have to come off their hormones? The short answer is no. Is there a number of years that they can be on hormones and then they have to stop beyond, which means my patient needs to come off hormones beyond 10 years, for example? The answer to that is really no. Um, continuation of hormone therapy or use of hormone therapy long term really ought to be tailored to the individual patient. We ought to be looking at their signs, their symptoms. Are they having mostly vasomotor issues? What are their medical comorbidities? And I think there's a lot of anxiety and fear about use of menopausal HRT in women beyond 65. 65 seems to be a number that I keep hearing, which is whatever patient hits 65, that's it. You got to yank her hormones, and then, whatever happens, happens. So I think part of the issue there is that it might be a misinterpretation of at least an arm of the Women's Health Initiative, which does talk about the increased risk of risks in women who are starting HRT at 65 and beyond. Key point here being starting, so initiation of HRT as opposed to just continuation of HRT. To the point that if we go back to like ACOG has a practice bulletin, so that's the number 141 that specifically talks about it. It says the decision to continue hormone therapy really ought to be individualized, and it has to follow a sort of a risk benefit ratio, and it's regardless of the age. And ACOG recognizes that women who are 65 and beyond may continue to have a lot of vasomotor symptoms. And so it is perfectly acceptable to continue systemic hormone therapy for women beyond 65, beyond 10 years, as long as you have a good understanding of the risk and benefit ratio there.
Yeah.
So, Becca, let me ask you a question.
Okay.
How do what do we know about the safety data
Ah.
that we use
So
in older women?
that is a great question because we don't have a lot of data specifically addressing this question. Now, we can look way back to like the Framingham data, the nurses study data, which looked at women who were using it in the way that women just used hormone therapy, and many of them stayed on it for a very long time. And that's in many ways why we built the WHI study, because we were seeing benefit to these women to be on hormones even into later years. So that's what they were really trying to suss out. But I think the best study, and I actually made slides on this. I was saying before we started, I actually made a couple of slides because I think
Yeah.
the study's worth looking at the actual charts because they're big and complex. But last year in Menopause, the journal, they published a study where they actually downloaded the data from Medicare. And they looked at all Medicare aged women, so women with Medicare Advantage, so over 65 years old. And then they categorized them as never users of hormones, has stopped hormones, and are currently continuing to use hormones. So these are women who probably started in their 50s at some point, and are still using hormones as they get above the age of 65. And so I'm going to pull up some slides, which is not something I usually do in these sessions, but I think it's really illustrative in this one case. So I want to make sure I do that. Now I just got to find the right window. So bear with me, guys. You know, my usual play from start. All right. So this is the study I was talking about, and I just put this up so it's in the video so people can go find the study. And so they had a huge data set. So if you look at this table too, you'll look at they had 1.5 million women who were currently using hormone and 9.4 who were not. So
Mm.
that's the level of N we have. And then they looked, so the first thing they looked at was death. Do they die at different rates? And so I highlighted in yellow here, it's the death rate per 1,000 person years. And if you look at just death from any cause, the rate is half in those who were continuing to use hormones. If you look at death from breast cancer, it's actually half of those in those who are continuing to use hormones. And if you go down, you'll see the same thing pretty much in all categories. Now, I always like to qualify this, which is this looks like we should be using it for everybody. I mean, dementia looks better,
Right.
any myocardial infarction looks better. This all looks really great. What we don't have in this data set is we don't have information about why are they continuing to use hormones? Are they
Right.
healthier at baseline than their counterparts who are not using hormones? So there's a lot we can't really control for in this data set, but at least it gives us sort of a peek into the data that says this might actually not be an unsafe thing to do and might actually have some health benefit. The other slide I pulled is that they actually looked at, oops, sorry, I went backwards. They pulled by different estrogen and progesterone combinations and looked at death from various cancers. And so I think this is really important because I think oftentimes we talk a lot about breast cancer in these patients and do the progestins increase the breast cancer risk? And what I've highlighted here is that estrogen without a progestogen, lower rate of every cancer, just across the board, whether it be death from cancer or just having those cancers. Estrogen plus a progestin, so we're talking about medroxyprogesterone acetate or agestin or ethindrone, levonorgestrel, any progestin like that. Slight increase in breast cancer, which is pretty much on par with the WHI.
Right.
No surprise there. If you actually split it out by type of estrogen, which is interesting because they couldn't do that in the WHI, it was all CEE.
Mhm.
The estradiol is a lower risk when combined with a progestin. And then the third box is actually progesterone. So the reason I highlight this is because we now tend to use progesterone rather than a progestin in most patients. And
Right.
there's a lot of wonder about whether it's a safer thing to use than a progestin in combination with estrogen. And some people even take some other data that we've seen in other places and say, oh, progesterone doesn't carry the breast cancer risk. Well, estrogen plus progesterone has almost the same breast cancer risk as estrogen plus a progestin over time. now, and it doesn't matter really whether it's CEE or estradiol. So I bring that up just because I think it's important when we're counseling patients to say, hey, you know, this progesterone seems to be better tolerated. We really like to use it. The French data from the E3N study says maybe the risk of breast cancer is a little bit lower with it in the first 5 years, but overall, over time, using a combination of estrogen and progesterone is going to increase your risk. The chart I did not, put on here. Sorry, I'm going to come out of sharing. Is that they also looked at cardiovascular events, and there were subtle differences. There were subtle improvements in cardiovascular events, and they looked at lots of different events, including death from cardiovascular disease. There were subtle improvements in some of the estrogen categories in these women, but they were pretty small differences. So we're talking like relative risk of 0.97, 0.98.
Mm-hmm.
Statistically
So nothing.
significant,
Yeah.
essentially nothing. Statistically significant
Right.
because they have 10 million women
Right.
to look at.
Right.
But the other side of that is also statistically not worse. We're not
Right.
seeing a
Right.
huge jump in cardiovascular incidence in these women. So I think this is probably one of the better things we have to look at in terms of the safety. They did try to do like a Cochrane meta-analysis of this, and they showed that women who started hormone therapy like less than 10 years after menopause had lower mortality in coronary heart disease, more DVT. That makes sense with what we know.
Right.
And those who started treatment more than 10 years after, they felt like the data only shows very limited impact on cardiovascular disease. So, it's interesting that in that combining all the data, it's a little different than what we saw in the WHI. It may also be because we're combining data that includes estradiol transdermal, which is a little bit different than conjugated equine estrogens. And then, there are some big observational studies from Scandinavia because the Scandinavians love to do big observational studies that show similar results to what I just presented. So,
So,
but
and
there's
it's also
conflict. Yeah.
it's also interesting you mentioned the difference
Uh-huh.
between conjugated equine and estradiol, and if
Mm-hmm.
anything, it might be a little like just this tiny bit safer for estradiol. And it's
Right.
an interesting observation because we get a lot of patients who specifically want conjugated equine estrogen because it's the more natural form or it's the
Right.
less
Right.
synthetic or processed
True.
form of estrogen. Seems
And I've
like
also
it's
seen discussions of like, well, you should be, if you want to get the cardio, if you want to get the benefits that we're touting from like the early studies, the nurses' health studies and the
yeah,
Framingham studies, you have to use conjugated equine estrogens. That's the only thing we have the data on. There is
right.
some other data that estradiol may be, even though it's transdermal, may be equivalent in those things.
Yeah.
But I think, overall, what I counsel my patients is, we're making a risk benefit balance for you. And we need to think about your family history. How long have you been on hormones? Why are you using them? What are you hoping to realize from them?
Right.
I do continue to tell them, even though this one paper does show possibly some benefit in dementia, I don't tout that as a benefit because I
Right.
think we have more data than not that it doesn't increase the risk of dementia, but it also doesn't decrease it when you started at the natural age of menopause. Different data in our premature ovarian failure patients. When you
Right.
start it at the time of premature ovarian failure and continue it at least through the natural age of menopause, there does seem to be some dementia benefit. That's a bigger discussion. We'll probably have to have a whole session on
Right.
that.
Right. Yeah.
But I do tell patients, it may have some health benefit. We know it has bone benefit, right? Nobody's arguing
Right.
that.
Yes. No one argues bone. Yeah.
And I guess my question to you is, do we have any data that tells us you have to use it for a longer period of time to realize those benefits? Like, is using it for 3 years fine? Or,
Right, right. So if we backtrack just a little bit in terms
mhm,
of bone health,
right.
then the obviously the data is clear, right? The bones love estrogen. Whenever you give
Yeah.
estrogen, whichever dose, however shape, your bones are
Yes.
going to love it, right? So the benefit seems to be for as long as you're taking it, right? So the second you stop your hormone replacement therapy, your risk is going to go back to what it was when you are off of hormones. So
Right.
it doesn't seem to be an accumulating sort of like, oh, I was on it for 10 years, and so that
Hmm.
should carry me for another 20 years, unfortunately. And
Yes.
then as far as cardiovascular, it's a little challenging there as well.
Yeah.
So anyways, if we look at the WHI with the estrogen only arm of the study, so there might be some cumulative sort of duration based benefits for
Mm-hmm.
estrogen there.
Right.
So if you want to look at risk ratios in the first 5 years of use of estrogen, that would be like over one. And then once we go beyond, was it 5 or 6? It may have been
6 years, I
6 years.
think.
Six
Yeah.
years. And beyond 6 years, that's when our risk ratio really drops. So we're seeing more benefit from that as well. So
Mm-hmm.
these are the ones I'm familiar. I'm very I usually mention to patients is unfortunately you don't carry bone health advantage, and there
Mm-hmm.
might be something
Yeah.
to as far as heart health goes.
Yeah.
So
And that bone health is something I think a lot of people are mistaken about. They think, oh, if I just take
yeah,
it for 5 years,
yeah,
I'm putting off my bone loss later in
yes,
life, but it's really not. You drop pretty quickly back to the starting point and go down from
right,
there. So I think that's something that's definitely worth getting out there. And we
right,
started to
right.
talk a little bit about dementia and the premature ovarian failure patients. I do like to mention that, I think one of the things we have never looked at is
Hmm.
really these long-term users in terms of dementia prevention. All of our studies say it does not prevent dementia in women who
Right,
use hormones starting at the natural age of menopause. It doesn't cause it. Whereas,
right,
some of the WHI studies showed that if you started over the age of 60 or 65, you might actually increase dementia. That's probably vascular dementia.
right.
But it shows it doesn't cause it, but it doesn't prevent it. But again, all of these studies, typically the intervention length was 2 to 5 to 7 years.
Right,
We don't have a large randomized control trial of women who've used estrogen for 10 or 15 years, except in premature ovarian failure patients, right?
right,
So can we extrapolate? No, these are different patients, but
right,
definitely, I don't tell my patients it's going to benefit them there, but I don't necessarily say it won't. I say we don't know.
right,
And I
right.
would really love it if somebody would like contribute 80 million so we can run that RCT.
Yes. Okay.
I don't think that's going to happen anytime soon.
No.
No.
Maybe right after we have another product for endometriosis on the market, right?
Yes,
Took us
exactly. Yeah, right
it
after they
took
fund
us 30
endometriosis
years for
research. Yeah,
GnRH
well, yeah.
antagonists and yeah,
So with all of those facts in mind, how do you
yeah.
counsel women on this?
So it's a complex and it's a very
Hmm.
nuanced conversation as well. It's really easy to just say, here's your standard hormone replacement therapy. There's your transdermal
Right.
0.05 milligrams of estrogen. Take your 100 milligram progesterone. You're good to go.
Uh-huh.
See you in 30 years. And so I definitely recognize that it's very nuanced, and I try to involve the patient as much as possible in the decision of how, should you continue, how do you continue. So it's very tailored, and it's very, very much after taking into consideration their unique situation. So
Hmm.
are they someone who would continue to have vasomotor symptoms well into menopause, because we know a significant portion do,
Hmm.
and what are their background medical issues? What's going on in the background where I may be more likely or less likely to recommend continuation or discontinuation? So it's definitely me weighing the benefits of continuing HRT. So here we're talking about definitely the benefits as far as bone health goes,
Hmm.
maybe potentially benefits as far as dementia goes versus the risks, which is,
Hmm.
every year lived, you're increasing your risk of DVT and PE and stroke, and that's regardless of what's going on with hormones. So
Right.
that's the risk benefit calculus that I make. And,
Hmm.
it does get tricky once we start talking about patients who are on HRT, and let's say, now we have a diagnosis of a hormone sensitive cancer, right? So
Right.
once you get into these patients getting into breast cancer, ovary cancer, uterus cancer, obviously I am very straightforward about no more hormones for you.
Right.
And essentially that calculus is really coming from the risk of recurrence of malignancy more than anything else. I think it's reasonable sometimes, if we're talking about a stage one endometrioid adenocarcinoma and they've already had a hysterectomy and they're feeling absolutely horrendously miserable, you can entertain like a
Mm-hmm.
transdermal estradiol. Um, that would be obviously while I make sure I'm looping in the oncology team and the primary care so no one freaks out about estrogen
Mm-hmm.
in the setting of cancer. There's that.
Yeah.
Um, and obviously, anyone who has a cardiovascular event or has a DVT or a PE, those are really big red flags for me because, again, every year of life lived
Right.
is higher risks of these conditions. So when you add estrogen, which is
Mm-hmm.
thrombogenic, on top of that, at that point, for me at least, it does the risks really don't justify the benefits. And I would then shift the conversation at that point in these particular conditions to let's talk about your non-hormonal options to control these vasomotor symptoms because there are a few and some are
Mm-hmm.
old guard meds, some are we have some new meds. Let's talk about that. So I want to make sure that I have all of this extensive discussion. I want to so the way I usually do it is I have annual check-in with my patients, and
Mm-hmm.
on the annual check-in I always tell them, all right, so in the last year, have you had a stroke, a heart attack, blood clot? Were you diagnosed with cancer anywhere? And if the answer is no to all of the above, the next question is, would you like to continue your hormones? Are you continuing having any vasomotor symptoms? And then we can make an informed decision as to whether to continue or not. And if the
Mm-hmm.
answer is yes to any of the previous conditions, then I usually say, I'm sorry, hormones are definitely not a good fit for you. Let's talk about other options. So, yeah, it's definitely a back and forth. And I think the more that your patients know about our decision making,
Mm-hmm.
the easier it gets because sometimes people can get frustrated where you're
Right.
like, why are you taking away my hormones? What did I do for
Right.
this? So if
Yeah.
you're explaining where we're coming from and why we're taking away hormones, it
Mm-hmm.
makes a lot more sense.
I
So
think you said something really important, which I
yeah,
also do with my patients, which is even when I'm
yeah,
starting the hormones, I
uh-huh,
have the discussion about how we're always continuously assessing risk and benefit.
yes,
And my goal is to do the safest, most beneficial thing for you. And when the risks become too high, we're going to have a different conversation. Like I preface it at 50. I
yeah,
preface it in my
yeah,
perimenopausal patient. I'm like, this may seem like something you want to be on forever because it feels great. And that's great as long
yeah,
as X, Y, and Z do not happen,
right, right,
and I think that's a really important, like starting the conversation that way really helps
yeah,
people to understand the journey with hormone
yeah.
therapy.
And so do you continue how often do you reassess that cardiovascular risk
So
with
that's a really
patients?
interesting question because I think that we don't have perfect tools for assessing that, right? A lot of people talk about using the ASCVD calculator, and I sometimes will
Hmm.
use that at the beginning point. So if somebody's maybe coming to me 7 or 8 years into menopause and wanting to start hormones, especially for bone health, I might run the ASCVD calculator just based on whatever data I have for them, just to see, well, where are you starting from a risk perspective? The
Right,
problem I have is that one of the biggest components in that calculator is age. And so it's going up every year, whether or not their actual risk is going up. So I
right,
don't certainly like use a calculator every year on them. I do assess risk in the sense that I ask them, if they have hypertension, I ask them if they're treating their lipids. So like we often see patients who come to us, I
right.
think I'm sure you do too, who say, "Oh my God, my lipids went up in menopause. I need hormones to bring them down." And
Yep,
my conversation with them is always, we can talk about hormones for a variety of reasons, but in the data, hormones bring down lipids by about 5 points, and that's not going to
right,
fix this problem.
right,
What you need is a statin because statins are well proven to be safe and effective in women. So,
right,
let's make sure we're doing everything for your cardiovascular health,
right,
and we can
right.
talk about hormones as a separate issue. So it's always just this sort of, it's a gentle reassessment. I'm not doing like a formal calculator every year. And I think that's sort of part of the conversation. I think also, you've talked a lot about, do we continue it for vasomotor symptoms? That is the
Yeah,
FDA response, right?
yes,
That is the response. That is what it's approved for vasomotor symptoms and for bone health. I have two 90-year-olds in my practice who are still on hormones because they feel better.
Yeah.
And at this point, I'm probably not doing a whole lot for their bone health. And I'm pretty sure they don't have vasomotor symptoms, but they've been on them
Right.
since they were 50 and they're happy and they are healthy. And I
Right.
continue their hormones for that because they feel better on them. And both of them had some episode somewhere in their 70s where someone told them to stop and they didn't like the way they felt and they went back on and they're fine. In
Right.
fact, one of them, she cracks me up. She's one of my favorite patients. Every time I see her every year, I'm like, oh, we need to assess, health and risk benefit. She's like, Doc, I'm 92. Who cares if this is what kills me? Something's going to
Right.
get me
Right.
at this
Right.
point.
Yeah.
And, there is some reality to that. So, yes, we have to say these are the two approved reasons why we can use hormones via the FDA, but there are off-label reasons why we sometimes use them. And sometimes those are reason enough to continue for some patients,
Right.
just as long as they understand the risk and the benefit ratio, I think.
And so, what do you think are the non-vasomotor symptoms that, in your experience, you've seen the most improvement with the use of HRT with?
So for my patients, the biggest ones that people tend to use them long term for are joint pain,
Mm-hmm.
sort of the brain fog, mental cognitive function. And some of that's hard to assess because, we do know that most brain fog sort of settles itself out several years into menopause. So are we really still treating that? It's hard to say. Sleep is a big one. A lot of my ladies just do not sleep well when they're not
Yeah.
on hormones. And we know how critical sleep is to longevity.
Mm-hmm.
And for some of them, it's sexual function. For
Right.
that 92-year-old, it's all about her 70-year-old boyfriend. So, you
Yeah.
know, there's
Yeah.
quantity of life and quality of life. We have to balance both of them.
For sure. I think the quality of life part of it is very
Mhm.
important. And I think I get a lot of, I just don't feel like myself
Yeah,
when I'm not
very
on
true.
it. And it's
Hmm.
very hard to like put your finger at exactly what we're talking about. But
Hmm.
I don't feel like me, and I don't like that.
Yeah.
Um, and the other thing I do is for non-vasomotor symptoms is I also try to manage expectations though, because
Right.
I do think there is a sort of an inflated sense of what estrogen can do for you.
Yeah.
So one of the things I try to remind people is that it's not going to make you lose 20 pounds.
No.
So all
Oh,
that
if only, right?
perimenopausal weight gain and yeah, that is not going to go away with
Right.
estrogen because obviously most will have significant amount of weight gain
Hmm.
and there is this idea that estrogen will help with that, so I'm always trying to also refocus on what it
Right.
can help with long term and
Hmm.
what it's not likely to help with.
Yeah, no, that's a really good point. And, that brings up another one of the things like I never tell my patients that estrogen or combined hormone therapy is going to help them with weight management all by itself. But I
Right.
do have a lot of patients who are very serious exercisers. So whether
Hmm.
they're athletes or they're, just really enjoy their lifting or their
Yeah.
marathon running. And for them, the estrogen can have a really significant impact on their
Uh-huh.
performance. And
Yeah.
so I think that's a reason to consider continuing medication if they're still doing those things. The other
Right.
interesting one that I think we never talk about, but is just like an interesting side note, is singers. So when
Hmm.
we lose estrogen, our voice timbre changes, it goes down. So for someone for whom professional singing is their profession, they may need to use estrogen as long as they're performing, because otherwise their voice will change, and that can be really devastating.
That's really interesting. I don't think I've ever had a singer patient. Yeah, now
I
I
know.
know
So
for
I
the
first heard
future.
about this at the Menopause Society. They had a
Uh-huh.
whole talk by someone who treats opera singers.
Oh,
And then we've had it since, we've talked about it again in terms of like testosterone and changing voice and why you shouldn't be giving testosterone to
right,
singers because you're going to
right.
lower their voice. But estrogen and testosterone have very significant effects on the vocal cords and, shown in study after study. So just something to think
Right.
about.
Oh, very, very interesting. Yeah, so it sounds like, there is not, there is certainly no guidelines that women should stop hormones by age X or
No,
after X number of years,
nope.
and that whenever we have our patients on long-term hormone therapy, we really have to be constantly assessing what's going on in
Mm-hmm.
the background in terms of medical comorbidities, and then
Right.
why they're on hormones,
Mm-hmm.
and kind of come to like a do a like a risk benefit ratio
Right.
and kind of assess and come up with a plan that both we and the patient can be very comfortable with. And yeah,
Yeah, I agree.
so
I'm going to throw you a curveball
okay,
because I just thought of it, and you
all
can
right,
kick it back to me if you want.
okay,
So say you get someone who's into their 70s and 80s.
uh-huh.
Do you change their hormone dosing?
I tend to de-escalate, yes.
Okay.
I do. And I know a lot of people will not. I know a lot of people will just find
Mm-hmm.
that magic dose of estrogen and progesterone that works, and
Mm-hmm.
they will, they'll just keep them on it. I'll be honest. In the 70s, I'll have the conversation about, can we try to de-escalate that estrogen a
Mm-hmm.
little bit? So if they're
Yeah.
on a point 0.1 or a 0.075, I'll say, can we try a 0.05?
Mm-hmm.
And I'll usually, most people are okay with it, right? We're
Yeah.
not taking away the hormones. We're just, we're going by the idea that we want to use the lowest dose possible that gives us the outcome that we want.
Right.
Um, so honestly, if you can get away with a lower dose, why not, right? So I'll usually start experimenting, and I
Mm-hmm.
usually will push them on up until that dose, and they'll know immediately. The dose that's too low, where everything comes flying back, I'm like, all right,
Yeah.
my bad. I'm gonna bump you back up. But
Yeah.
yes, I do dose de-escalate.
I tend to too. And I preface that as well. If I have someone who's
Yeah,
saying, I'm going to be on this forever, I'm like, that's
yeah,
great, but we're going to have a conversation in your 60s and 70s about getting you to a dose where I'm first of all, transdermal, because I have some patients who
right.
like the oral and they take the oral through their 50s and into their early 60s. I'm going to say there's going to come a point where I want you on transdermal. And
Yes,
I want you at a dose at least under 0.05 because that's where we have the best data that your clot risk really isn't increased. And as you
right,
age, it is increasing. So
right.
let's balance those risks. My 80, 90-year-olds, most of them are on 0.025. They don't need
2.5,
a lot.
exactly. Yep, yep.
And that's where I use that dose. I know a lot of people start there. I never start there. If I've got a
Yeah, I
50-year-old in my
don't either.
office, the lowest I'm going is 0.05 because they're not going to get
Yes,
any symptom relief from
exactly.
0.025. But unless they're a very tiny person, I do have a
Right,
couple very tiny patients who don't feel good on that much estrogen.
right,
Um, but yeah, I also do the same thing. It's just about managing risk. And we do have these good studies that show us that transdermal estrogen under 0.05 does not seem to increase clot risk or change clotting factors in low risk patients. Always add that qualifier because this does not apply to someone who's got a clotting factor disorder or has had
right.
a clot.
Yeah, yeah.
Um, and I think it's the better part of valor. We're always trying to do the best thing for our patient. We're not taking their hormones away. We're just trying to keep them at the safest possible dose.
Right, right.
Um, we've
Do you
had a
find
lot of, go ahead.
do you find that the ultra low dose transdermal estradiol does anything like the I'm talking about the 0.01, what was it? 0.017?
0.014, I think they
14.
made.
14. Okay.
So interesting question. I don't know how much it does for symptoms.
Hmm.
I doubt much. They made it for bone health. That was what they were testing. And even at 0.014, 90% of women stabilized their bone health. So
Nice.
I see there's a question in our chat. What if our goal
Oh,
is bone health?
yeah.
Someone had heard that even the highest dose patch might be too low to get maximal bone benefits. It's actually the opposite. When we tested a 0.014 patch, it gave bone benefit. So there is no dose you have to get to for bone benefit. Any dose of estrogen is impacting bone benefit. And so it's perfectly safe to dial down to the 0.025. I don't even think they make the ultra low dose one anymore, or at least I haven't seen it available. So,
No, I have one patient who cuts the 0.025
in
for
half.
a zero. Yeah,
Yeah.
yeah. Makeshift ultra low dose.
Yeah.
Yeah.
I think that I'm not sure there's I would probably wouldn't use the 0.014 even if it
Yeah,
existed. But
yeah,
I do use the 0.025 in some of my much older patients who are really on it for supportive bones because they have significant osteopenia or even osteoporosis, and we're trying to just
right,
stabilize them and keep them from breaking a hip. Absolutely. And it does stabilize them. Like we can see it in studies at any dose.
right,
Um,
right. And
so
then
the,
there's some improvement in the joint pain too. Like
oh
forget
yeah.
outside of osteopenia and osteoporosis. And I think part of that is probably a little bit of the anti-inflammatory
Hmm.
properties of estrogen, right? So that
Yeah.
plays into it a little bit. And that seems to be one of the things that I get a lot of relief from patients. And
Yeah.
one of the first things
Yeah.
to come back if they discontinue hormones is the joint
Yeah,
pain.
we definitely see
Yeah.
that. And not to say that estrogen treats like osteoarthritis. If you have
Right. Right.
osteoarthritis diagnosed on X-ray, we're not going to treat that. But
Right.
just the general joint soreness, tenderness, that can really be benefited by estrogen. I wanted to say to our attendees, please feel free to put questions in the chat. I'm sort of reading them on the side as we go and sort of, trying to slip them in.
Hmm.
And someone asked if you're using 0.025 for bone health, you still have to use some sort of progestin for the uterus, correct?
Yes, correct. Yes,
Correct. Yes,
very
uterus
correct.
progesterone
That's
or
it. Yeah.
progestin,
It's a one to
whichever.
one ratio. Yeah.
Yeah. Now, with the 0.025, you can get away with some of the cyclic regimens or maybe, a little bit less progestin, but I find it's just easier for patients to take every day. Nobody wants to have a period.
Right.
So I find the cyclic regimen's a hard sell.
Right.
Um, and then, I think that someone else has asked, is there a dose to help with bone joint pain? Everybody's different in my experience, don't you think?
Yeah, I don't think there's a specific dose because again, all of these doses are based on they were looking at vasomotor symptoms. I don't think they
Mm-hmm.
uniquely looked at that.
Uh-uh.
So my experience has been that by the time that dose is treating the vasomotor symptoms, it's probably helping with the bone health as well. So, but
Yeah,
I'm
and
not
the joint
tacked to
pain.
a
Yeah.
and the joint, yeah, and the joint pain.
Mm-hmm.
So I don't usually have a specific like dose in mind. Oh, if you're having
Mm-hmm.
bone pain, this is what I'm going to put you on. If you have VMS, this is what I'm going to put you on.
Yeah. Yeah.
Most of how I start, like the dosing for HRT, usually starts with I use middle of the road dosing, right? So 0.05, and
Mm-hmm.
that allows me to go up if need be. If there's improvement, but we can improve a little more, I'll go up. And then if they start having, nausea, headaches, breast tenderness, I'll drop the estrogen dose so I can play around with it a little
Mm-hmm.
bit. I know a lot of people start with like 0.025 and do a very sort of stepwise keep
Mm-hmm.
bumping up, and I think that's fair, right? To start with the lowest, start low, go slow. That's totally fine. I find though
I just
that
find my patients don't like it. Like
yeah,
they've gotten their hormone prescription, they want to feel
yeah.
better.
Yes, yes. And especially if we're talking about like late perimenopause, early
Yeah.
menopausal, I
Yeah.
I rarely get away with like a 0.025 in that
No.
cohort. Like a 50-year-old,
Yeah.
usually no.
No, it's not
It's
going to
gonna be a
work.
lot higher.
And they've
Yeah,
been a lot higher. That's the thing. Remember,
yeah,
all of these doses, even the zero point 0.1 patch, are much, much lower than anything we're putting out during our reproductive life, right? So reproductive life in the course
right,
of a normal cycle, the normal estradiol levels go anywhere from 12 at the very beginning up to as high as 500. And in
right,
perimenopause, they can shoot into the 900s, 1000s with some of these luteal out of phase ovulations. When we're using these patches, we're probably getting women somewhere into the 30 to 100 range,
right.
which is fine. And there's no value we need to achieve. So that's the other thing we get asked a lot, right? Do I need to do a test and make sure they're over a certain amount? No, you don't.
Yeah,
If their symptoms are relieved, you're in the right range. But
yeah,
we're
yeah.
still we're still we're working within a range that is all well below the peak that they've been seeing during reproductive life. So feel reassured about
Right,
that.
right.
And again, dose for bone pain, joint pain, there is no one dose. Whatever solves that symptom. So I like Hannah, start at
Yeah,
0.05 and then I see them back in 2 to 3 months. Because I do tell them joint pain takes a little longer to resolve. You're
uh-huh.
going to get a handle on those hot flashes in a week or two
Yeah,
for the most part. But joint pain takes a little longer. It's an inflammatory process. It has to calm down. So at 3 months, I ask, is that better or is it not? And do we need to adjust based on that? Really?
Right. Right.
Um, and then someone did ask, why do you gain weight with menopause? So I'm going to punt that one to you, oh, expert of
Yeah.
obesity.
Yeah, yeah. So a big part of that is not necessarily directly related to estrogen and the ovaries. A big part of that is your basal metabolic rate is dropping, and
Yeah.
it just so happens that the more precipitous drop in the basal metabolic rate is happening at the same time that you're going through perimenopause and menopause, right? So just because these two events are happening at the same time, it doesn't necessarily mean that one is, causing the other one. The other thing that is profoundly unfortunately underestimated during this time is whether we actively think about it or not. Perimenopausal women have profound changes in their lifestyle. So even if they say, "Hey, but I haven't changed anything," or it's usually that age group where you have the sandwich generation. They're taking care of older parents. They have younger kids that they're
Mhm.
taking care of. Their careers are taking off. They're spending more time, whether they realize it or not. They're spending more time behind, sitting at a desk. They're not as active. And they may be grossly underestimating what they're eating and how they're eating it. So it's a combination of things, mostly driven by the fact that the basal metabolic rate is dropping, but also lifestyle does play a bigger than we think, or maybe we like to think, dose
Mhm.
in this, or role in this transition as well.
And I
And then,
always mention sleep,
yeah, yeah, and
sleep
sleep.
disturbance.
Yeah. I mean, to the order of like 400 calories a day that you can,
Right.
right? Um, if basically, if you're not sleeping appropriately, right, your ghrelin levels are going to be higher, and that's going to translate into more calories that you consume, to the point that they studied it, and roughly those calories
Mhm.
are 400 extra calories a day that
Mhm.
you're eating if your sleep is not teed up.
Yeah.
So I think it's a perfect sort of fire of all of these different things that cause weight gain. But,
Yeah.
it's not estrogen, right? It's not estrogen dropping causes weight
Not
gain. And,
directly.
and,
No.
and right. And the proof in that is that when we replace the estrogen, that weight doesn't, right, come off.
I
I would
know.
have loved that. We would have been really, really rich.
Oh yeah.
If
We'd
we
we'd
were,
be the most popular doctors on the block, right?
I know,
Um,
I know.
and
We'd
somebody
be
asked,
live
is
one rich.
yeah, somebody asked, is this why we're recommending strength training and resistance exercise to help increase muscle mass to increase basal
Yes,
metabolic rate? Absolutely.
yes, yes,
Muscle burns calorie.
absolutely. Yes,
It also
absolutely.
supports your bones. Twofer.
Yep, yep,
Okay.
absolutely.
So I'm going to read off a question and answer it. Is there any data using progestin-containing IUD for endometrial protection with transdermal estrogen, and does this equate to a lower breast cancer risk? So great question. Yes, we have data for the 52 milligram IUD. So that's the Mirena, the Liletta in the United States. That they are good for 5 years to counter menopausal hormone therapy. We have no data beyond 5 years. So though they are approved out to 8 years for contraception, that 5 to 8 year window, we have never looked at whether there's still enough progestin
Right,
left to counter menopausal hormone therapy, and we should seriously be replacing them every 5 years.
right,
There were some studies in Europe with a much lower dose IUD that they tried for menopausal hormone therapy, and they got endometrial lining growth. So we know there is a dose at which it gets too low to protect the lining. So really, Mirena or Liletta to 5 years. Yes, we have data that that works. Second part of the question, does it reduce your breast cancer risk? If only. Unfortunately, Mirena also comes
yeah,
with a breast cancer risk.
yeah,
So you're still getting some small portion of systemic levonorgestrel. And I know a lot of women think that just because it's mostly local that we're really reducing that risk. We can't really say that. We have to counsel them that there is still a risk.
right,
Whenever we use a progestin, there is just that risk. It is a small risk. It is one additional case in 1,000 woman years. This is not a big risk, but it's there and we can see it. And we've seen it with studies in women using Mirena for contraception around the perimenopause. We see a slightly increased risk. It's just there.
but it's
Nelson,
important. we also need
Mm-hmm.
to frame it in the sense that yes, there's increased risk, but just to begin with, your lifetime risk of breast cancer is 1 in 8, right?
Yeah,
It's
it's
high.
huge.
It is
Yeah,
very high, and we can't do anything about that number. So just
right.
adding that one extra case per,
1,000 woman years is not much.
yeah, yeah,
And I think the other thing that you bring up a good point. I have another good point. Just because it slightly increases the incidence of breast cancer does not mean it causes it.
right,
And I want you sometimes I like to say every woman in her reproductive life has been exposed to estrogen and progesterone for about 35 to 40 years. Not every woman gets breast cancer.
right,
So it is not directly causative. It's not, if I take this, I will eventually get. There is an association. There is some reason why maybe that's popping up. It may be partly just that once that breast cancer develops, because really the causative factor with breast cancer is impaired DNA repair. We know that. It's from multiple insults to those cells over the course of your life. So once that insult happens and those cells start to proliferate, I think what we're seeing is that having that particular progestin around maybe helps them to proliferate to discovery a little bit faster.
right.
Someone asked if anyone is trialing low-dose estrogen patch on women with mild Alzheimer's, and what about comorbid ADHD? So Alzheimer's, no one is trialing that. Probably wouldn't do any good. Alzheimer's has a totally different causal pathway, so we're really not going to get a whole lot of benefit here. They did do way back when, and we're talking in the way back, so this is in the 50s. They did go into nursing homes and in 85-year-olds who were showing some level of cognitive decline. They gave them estrogen for 3 months and documented on, tests of cognitive decline that they got slightly better while they took the estrogen and then it got worse again. But they only gave it to them for 3 months. So what we don't know is when you give an 80-year-old that for cognitive decline, what do you then do to her cardiovascular health or stroke risk? So not recommending that, but can there be some temporary help? Maybe. We just aren't trialing that. In terms of ADHD, that's an interesting question. Um, we definitely see more and more women being diagnosed with ADHD as they transition through the
Yeah,
perimenopausal
for
time.
sure. Hmm.
And I like to say that this is partly probably because they were able to manage their mild ADHD that had no hyperactivity, so they were never diagnosed. And then their brains just go slightly off the rails, and we have all our screens, and we're in the sandwich generation, and they have more responsibility at work, and it just all goes to hell in a handbasket.
Right,
I think some of it, I've seen many women treated with ADHD meds, and not all of them get better because not all of it's ADHD. Some of it's a little bit of anxiety, some of it's a little bit of brain fog. There are a lot of factors that go in there. So, can estrogen help with some of that? Yeah, it can help with a lot of the brain foggy type symptoms and some of the
right.
short-term memory stuff.
Yeah. I've definitely seen that uptick in my patients in their intake forms with a diagnosis of ADHD. I'm seeing that a lot more now than I did like 5 years or 10 years ago,
Yeah.
for sure.
And we definitely have underdiagnosed women and
Uh-huh.
girls with ADHD because girls do tend to have the non-hyperactive forms or the hyper-focused forms, and those are considered good things. Like if you can hyper-focus on a task, why
Yeah,
would you want to medicate that?
right,
But, so some of that is just we're now diagnosing. But
right,
I think I agree. Sometimes it's not really ADHD, it's sort of a combination of brain fog and life.
right, right.
Yeah, I do a podcast on perimenopause with Amy Vodich, and one of the things she loves to say is, basically your brain is a Macintosh laptop. And after 15, 20 years, you get the spinning beach ball of death whenever you try to do anything because your RAM is just
Yes,
full.
yes,
Your RAM is full. The
yeah,
runtime memory, it's gone.
yeah,
So we're all just
yeah.
living in the spinning beach ball of death right now. Um, Someone asked if we see a comparable suppression of FSH on a lower dose patch.
I mean, we should be able to suppress the
Yeah,
FS. Is there a study specifically that looked at different doses and
there are.
how
Yeah.
how effective it is at suppressing?
Mhm.
Okay.
There are
So,
not much, like, because our
okay.
goal is that's not the outcome of interest, right? We're
Right,
studying,
right.
are we making women's lives better? But when they do check FSH, pretty much any dose does suppress it. The other thing
Mm,
to keep in mind is FSH suppresses itself as you get further into menopause
right, right.
because your brain basically gives up on your ovaries. So
Yep.
even if you don't take any hormones, it does drift
Yeah, it
down over
peaks and
time.
then it starts.
Yeah.
Yep.
Yeah.
Yeah. It's the final, like, I
Hmm.
give up. That's it.
Yeah.
I'm
These
not
ovaries
messaging these
are not
ovaries.
speaking to me.
Yeah, exactly.
I'm going to throw this one to you because we all know how I feel about it. What are your thoughts on the new craze of pellets, testosterone,
Yeah.
estrogen, and then using oral progesterone?
Yeah, so in general, when I'm counseling people and how should I take my estrogen, I'll usually say, hey, you can take it oral, it comes in an injection, you can take it transdermally, you can use a gel, or you can have pellets. And right off the bat, I'm going to tell you right now, you don't want to use a form of hormones that's hard to reverse. So immediately just don't do injections and don't
Hmm.
do pellets.
Right.
So I'll usually say, what are you going to do if you have a lot of side effects and you're not tolerating it well? Well, tough luck, right? And more so for pellet, and specifically for pellets, I really discourage people from getting pellets because, again, I'm not a fan of things being compounded. I'm not a fan of, like, let's make this in Joe Schmo's backyard here and kind of
Hmm.
add a hint of this and add a hint of that.
Right.
So in general, I'll usually tell people stay away from pellets because it's not standard anyway.
Mm.
And bigger picture is, even with standard IM dosing of estrogen, I'll stay away from that.
Yeah.
So I'll usually push transdermal as much as possible. And if sometimes people have rashes, sometimes they don't tolerate the patch, or the patch keeps falling off. That's fine to move to oral estradiol at that point. Um, Second part of the question, testosterone. Um, Very mixed feelings about that. So I really think that obviously testosterone does
Hmm.
serve a function in women, right? Because your ovaries produce testosterone. 50% comes from your ovary, and 50% is a conversion from androstenedione from the adrenals. So obviously it serves a purpose. So I'm
Hmm.
not going to sit here and say, oh, you should never be on testosterone. It's not supposed to be there. It's not natural. That's not the point. I just am not convinced that how we're doing it right now is the appropriate way to be doing testosterone, because right now it's truly the wild west of how we're dosing. Either we're
Right.
doing like 1/16th dose of a male transdermal testosterone, or we have well, you take your syringe and you withdraw like 1 cc of the gel, or you
Right.
compound it by your local pharmacist. So I think there are too many unknowns right now with testosterone and appropriate dosing and possible side effects, and how quickly too, by the way, you can go
Right.
from feeling great on testosterone
To
to
feeling like
your
ass.
and your voice dropped, and now you have a
Hmm.
beard and you have clitoromegaly, all of which is not reversible, right?
Right.
So
I think
personally, I'm
that's the
not a
one
big.
thing patients aren't told when they're started on testosterone is that if you start to
Yeah.
see the side effects, we need to stop because these are unreversible side effects.
Right, right. So where it stands right now,
Hmm.
I usually tell patients, nah, I'm not a fan of testosterone. I'd hold off,
Yeah.
until the science catches up with using testosterone specifically in women.
Yeah. And I want to say the science is trying to catch up. So I'm going to bring up a couple of points. One
Yeah,
is I am 100% never a pellet person. There is no
right.
reason
Yeah,
to ever use a pellet.
yeah,
Pellets are a compounded product. They're not regulated by the FDA. Using the same synthetic hormones we can get in a perfectly safe FDA regulated form. So there's no
right.
benefit and there's only risk, and it's a cash pay service. So if someone's counseling you to get a cash pay pellet and not mentioning the patch, which you can get at your pharmacy for $20, run.
Right, right.
Um, Second thing is testosterone. So Dr. Susan Davis, she's in Melbourne. So she's at the University of Melbourne, is sort of the lead researcher on testosterone use in women. And
Right.
she's done several small pilot studies that really don't show a whole hell of a lot of benefit of testosterone for things like energy and mood and general well-being. She
Hmm.
did a tiny pilot study that showed maybe some benefit, and then she followed it up with a slightly bigger study that showed no benefit. More
Right.
importantly, the only time they also looked at like muscle and things like that, and the only people who got any muscle benefit were almost in a male range, which makes sense. Men have bigger
Right.
muscles than women.
Right.
So if we get you to a transitioning range, you're going to start looking like a man. They have in Australia female dosed products. So they are currently doing a study on safe
Hmm.
dosing within the female range to look at all of these issues. And they should have data late this year, early next year from that study. will have a lot more information. But we in the US, like you mentioned, Hannah, we do not have a female dosed product.
Yeah.
So what are bioidentical products versus FDA approved products? They are the same. Thank you for that question. Bioidentical is a
Yep.
marketing term. It's not a medical term.
It's a gimmick. Yeah.
It's a gimmick. It was brought up in the early thousands when the WHI published and everybody was afraid of hormones. People started selling compounds and calling them bioidentical to make them sound safer. All of the molecules used for hormone therapy have about equal safety data, whether they're the more natural or estradiol and progesterone, which are the synthetic compounds that look like the molecules we used to make, which are sometimes referred to as bioidentical, or they're the other ones. They all have about a similar safety profile. But more importantly, I think what I tell people is they're all synthetic except for conjugated equine estrogens. Nothing is natural, nothing is plant-based.
Right.
What you should always be looking for is an FDA regulated product, whether that's a patch, a pill, a gel, a spray. Um, Use something that's regulated by the FDA because somebody walks into that pharmaceutical laboratory and pulls product off the line and makes sure that the dose is exactly what it says it is.
Yeah.
If you're getting something from a compounding pharmacy, nobody is checking.
Nobody knows.
Nobody knows. We have run out of time with all these phenomenal questions. I just want to thank everybody for all these questions. I'm really glad we got to have this discussion. I'm going to pop into the chat just for everybody who's still on a couple of references. One is the paper that I talked about, one is another one. Just so you have those if you want to reference back to them and sort of look at some of this data in depth. That Medicare study is really interesting to read. I found it really fascinating, and I think it's a great start into looking into these longer use issues. So thank you, Hannah.
Thank you. This was
This was
fun.
it was a really good discussion. Thank you everybody who
Yep.
attended and everybody who watches later.
All right.
Have a good
Take
night.
care, everyone. Bye.
Good night.